Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh and good day. For this lecture, I'm going to cover the cranial nerve topic. It is hoped that at the end of this topic, you should be able to identify the cranial nerve structure, explain the functions of cranial nerves, identify the blood supply for cranial nerve, explain the clinical features or disease related to cranial nerve. Let's go through the structure of cranial nerve. Cranial nerve is a bundle of motor fibers that innervate muscles or gland. These bundles can carry impulse from sensory receptor or show a combination of these fibers, meaning that cranial nerve can serve only efferent or afferent functions or combinations of both. These cranial nerve emerge through foramina or fissures in the cranium and are covered by tubular sheets derived from the cranial meninges. There are 12 pairs of cranial nerve, which number from 1 to 12, from rostral to caudal, according to the attachment to the brain and penetrations of the cranial dura. These cranial nerves are named based on their general distributions or functions. In general, the exit of cranial nerve is from the brainstem. Let's start with cranial nerve 1, visceral afferents, which is for special sense of smells. These are the locations of olfactory nerve. The olfactory nerve or cranial nerve 1 is rarely tested because of the deleterious effects of smoking and sinus disease on the sense of smell in the general populations. Any lesions to this cranial nerve will lead to total loss of the ability to smell, or they call it as anosmia, which is always associated with inability to taste food, which is ageusia. Patients also can suffer from dysgeusia, which is an appealing or altered sense of taste, and parosmia, which is an altered or changes in the perceptions of odors. Next is the optic nerve. Optic nerve extended from the caudal aspect of the eye to the optic chiasm. This is your optic chiasm junction. This nerve is enclosed in a sleeve of dura and arachnometer. The cranial nerve receives blood supply from the ophthalmic branch of internal carotid artery, posterior ciliary arteries, and central retinal arteries. Thus, the subarachnoid space extends along the optic nerve, which is surrounded by cerebrospinal fluid. For this reason, any increase in intracranial pressure may be transmitted along the optic nerve and can cause blockage of exoplasmic flow at the optic nerve head. These exoplasmic stasis results will cause swelling of the optic nerve head. The damage to the optic nerve may result in partial or complete loss of vision in that eye. The third cranial nerve is the oculomotor nerve. The oculomotor nuclei is located within the ventral portions of the periaqueductal gray, just posterior to the medial longitudinal fasciculus, and it is present in about the rostral half of the midbrain. So this is your oculomotor nerve. And this is the locations of the periaqueductal gray matter at the midbrain level. If you can see, this is cross-sectional view of the midbrain. The oculomotor nerve has smaller subnuclei that contain sensory efferent motor neurons that innervate all the extraocular muscles except the superior oblique lateral rectus. Meanwhile, the visceral efferent fibers in the oculomotor nerve innervates the sphincter pupillae and ciliary muscles. The sympathetic fibers of this nerve is innervating the dilator pupillae muscles and the superior tarsal muscles. Any lesions to the oculomotor will cause patients to experience diplopia, which is double visions, And patients also can be non-reactive to light because of the sphincter pupillar muscle is denervated, and patients will have upper eyelid exhibitosis, which is drop of the eyelid, because of the levator palpebrae has been denervated by the oculomotor nerve lesions. Next is the trochlear nerve. Trochlear nerve is the cranial nerve number 4. There are two cranial nerves located in the midbrains, which are the trochlear nerve and the oculomotor nerve. The trochlear nerve is the only motocranial nerve formed entirely by an axon. This cranial nerve innervates the contralateral superior oblique muscles. Depending on where are the lesions, the patient will show paralysis of the superior oblique muscles on the same side. Trochlear nerve work together with other fibers to control vertical gaze center. Any sudden cortical damage, such as stroke or trauma, involving the frontal eye field will result in involuntary conjugate deviations of the eye to the side of the lesions. Next is the cranial nerve number 5 or trigeminal nerve. This nerve is located over the spinal cord and medulla junctions. So this is your spinal cord and medulla junctions, and these structures, if you can see here, is your cranial nerve, which is rostral levels at the mesencephalons. The trigeminal nerve is a mixed nerve. It has the sensory and motor component functions. This is the largest cranial nerve. Together with vagus, glossopharyngeal, and facial nerve, trigeminal nerve conveys sensory input to entire face, external ear to the cornea and conjunctiva, the mucosa of the nasal cavity, the upper and lower teeth, the oral cavity including the tongue, the lining of the pharynx and larynx, and proprioceptive inputs for the muscles of mastication and extraocular muscles. The sensory information relayed by this nerve is related with pain and thermal sensations, discriminative sensations, and proprioceptions. The motor nucleus of trigeminal nerve innervate the muscles of mastication, including the medial and lateral patagoid muscles, the tensori tympani and tensovelli palatini and mylohyoid, and the anterior belly of the digastric on all ipsilateral side. This motor nucleus receive afferent fibers which involve in the jaw reflex. Any lesions to the trigeminal nerve or its central nuclei will produce sensory symptoms in the peripheral distributions of the nerve or its individual divisions, and paralysis of the mastication muscles on the ipsilateral side. Patients may experience sensory deficits like loss of pain, thermal and tactile sensations on the ipsilateral side of the face, much of the scalp. At the same time, patients may lose sensations in the oral cavity and at the same side. However, any injury to one trigeminal nerve does not necessarily cause loss of the jaw jerk reflex. Next is the cranial nerve number 6, which is abducens nerve. The abducens nuclei is located internal to the facial colliculus and surrounded by internal genu of the facial nerve. This is the internal genu of the facial nerve. This is the facial colliculi. The abducens nucleus contains motor neurons and interneurons. It innervates the medial rectus muscles. This is your medial rectus muscles. Any lesions to abducens nerve will lead to intranuclear ophthalmoplegia, which is an ocular movement disorder, which is inability to perform conjugate lateral gaze. Patients may also present flaccid paralysis of the ipsilateral lateral rectus muscles. The affected eye is slightly introverted and unable to perform abductions on the attempt to lateral gaze on the same side. Paralysis on the medial rectus on the opposite side, seen in attempted gaze towards the side of the lesions. And patients also tend to develop one and half syndrome, which is a horizontal movement disorder of eyeballs. These conditions involve weakness of the ipsilateral lateral rectus muscles and contralateral medial rectus muscles. Next is the facial nerve. This is the cranial nerve number 7. The facial nerve motor nucleus is located in the pons, just rostral to the pons medulla transitions. So this is your pons. This is junctions between the pons and medulla transitions, and this is your facial nerve. The facial nerve gives a small branch opening of sensory efferent motor fibers that supplies stapedius muscles and large branch of the chorda tympani. This is chorda tympani. This is stapedius muscles, which is the inner ear. The facial nerve have two varieties of sensory fibers. The first fibers is taste fibers, which carry the visceral efferent functions. These fibers convey sensations from sublingual and submandibular salivary glands and mucous membranes of the palate and nasopharynx. It collects taste information from the anterior two-thirds of the tongue. The second sensory fibers is the facial nerve cutaneous sensory fibers, which has somatic efferent functions, which is responsible for facial expressions muscles. The facial nerve exits the styloid foramen, pass through the and around the parotid gland, where the nerve divides into 5 branches of terminal. So this is your styloid mastoid foramen. And this is the parotid gland. Most of the fibers that remain in the facial nerve at this point provide motor innervations of the muscle facial for facial expressions to the posterior belly of digastric muscles and styloid muscles. In addition, the facial nerve contains a relatively small cutaneous fibers or sensory efferent that supply portions of the external ear and external auditory canal. Any lesions of the efferent fibers over the face motor cortex and in the terminal capsule will cause drooping or sagging of the corner of the mouth, collateral to the lesions when patient is asked to smile voluntarily. And even patients sometimes can smile involuntarily or spontaneous in response to amusing comments or situations. Any peripheral lesions of the facial nerve, basically in the infranuclear, will produce lower motor neuron symptom. Patients will exhibit a loss of voluntary control of ipsilateral facial expressions muscles in the upper and lower portions of the face. This motor or Bell palsy deficits is accompanied by decreased mucosal secretions in the nasal and oral cavities. They also will show decreased tear fluid productions and salivary gland output. All is on the ipsilateral side. Patient will also develop dysfunctions on cutaneous sensations of the external ear and external auditory canal. Patients may experience decreased taste sensations, which is related to visceral efferent fibers on the anterior two-thirds of the tongue, but not the somatic efferent functions of the face. Hyperacusis on the ipsilateral side may happen. Hyperacusis is abnormal sensitivity to sound in resulting pain and discomfort. Any lesions over the distal to the ganglion and facial nerve will lead to decreased salivation, taste, and hyperacusis. Patients also may have decreased functions of all facial expressions on one side of the face. Additional deficits that can be seen due to facial nerve lesions are facial diplegia. Patient may also show hemifacial spasm. Hemifacial spasm is irregular and sometimes painful contractions of the facial muscles that may be triggered by voluntary movements of the facial muscles. Hemifacial spasm may follow by an episode of Bell palsy or results from compressions of the root of the facial nerve by lesions or vessels. Patients also may experience bilateral paralysis of the facial muscles. Next is the vestibular cranial nerve number 8, which is vestibular cochlear nerve. The 8th cranial nerve is located laterally at the brainstem. The cochlear portions of this cranial nerve is exclusively known as afferent sensory, which originates from the cells in the spiral ganglion located in the cochlea. The sensory efferent part of the cochlear fibers synapse to the inner and outer hair cells, and the function is to inhibit the ability of the hair cells to respond to stimuli. The vestibular divisions of this cranial nerve originate from semicircular canals, receiving input from the ampullae and semicircular canals and the utricles. The vestibular component of this nerve have important central connections to the cerebellum, oculomotor nuclei, and to other brainstem centers, which is related to balance, positions, sense, equilibrium, and coordinations of eye movement with head movement. Any damage or injury to the cochlea spinal ganglion of this cranial nerve will cause loss of hearing on the side of the lesions. This type of hearing loss is sensory neural hearing loss. Lesions within the brainstem or at any higher level may affect the patient's ability to precisely interpret or to localize a sound in space, but such lesions does not result in deafness in one ear. Patient may also present with tetanus. Tetanus is a ringing, hissing, or roaring sensation perceived by the patients. Any damage to the vestibular fibers of this cranial nerve may result in vertigo, a perception of movement, and nystagmus that may be accompanied by nausea and vomiting. The vertigo may be subjective or objective. For the vertigo, the patients may either experience subjective vertigo, where the patient may sense that he or she is moving. For objective vertigo, this is when the patients perceive that object in the environment is moving. Patient may also experience nystagmus or rhythmic oscillatory movements of the eyes. Lesions of the vestibular nuclei and central connections, mainly in the cerebellum, will result in a sensation of ataxia and unsteady gait in the patients, where patients will feel that his or her balance is off, and nystagmus. Overall, any lesions over the vestibular cochlear nerve may result in hearing loss, tetanus, dizziness, and related problems such as ataxia and vertigo. Next cranial nerve is cranial nerve number 9. This is glossopharyngeal nerve. This nerve exits the medulla at the post-olivary sulcus, leave the skull via the jugular foramen. The glossopharyngeal nerve has two ganglia, which is an inferior ganglion containing visceral afferent cell body and superior ganglion containing the somatic afferent cell body. The motor fibers part of the glossopharyngeal nerve innervate the stylopharyngeus muscles, which is responsible for swallowing and participate in the efferent limb of the gag reflex. For sensory fibers, the sensory somatic afferent fibers of this nerve originate from the cutaneous receptor on a small area of the pinna and external auditory canal and on the posterior third of the tongue. The sensory visceral afferent fibers convey information from the parotid gland and the oropharynx with an especially important input from the carotid body. The carotid body contains chemoreceptors that are sensitive to changing level of oxygen and carbon dioxide in the blood. Any lesions on the non-cranial nerve are relatively rare but may occur in combinations with the vagal and accessory roots at the jugular foramen. Deficits related to only glossopharyngeal nerve damage are largely restricted to diminished sense of taste from the posterior third of the tongue and loss of stylopharyngeal contractions on the site of the lesions. This may affect the gag reflex. Another common disorder involving this cranial nerve is glossopharyngeal neuralgia. This disorder is characterized by attacks of intense idiopathic pain arising from the sensory distributions of the nerve, possibly area pharynx, caudal parts of the tongue, tonsil, and possibly area of the middle ear. The attack may be spontaneous or may result from artificial stimulations of the back at the oral cavity or from swallowing or even talking. Glossopharyngeal neuralgia may be severe and can be seriously disabling. Next is the vagus nerve. This is cranial nerve number 10. This nerve is located at the intermediate positions between the midline and lateral aspect of the medulla. It exits the post-olivary sulcus. Vagus nerve contains both motor and sensory components. The cranial nerve exits the cranial cavity via the jugular foramen and forms two branches at the foramen. The superior ganglion branch of this nerve contains the cell body of somatic afferent fibers, and the inferior ganglion of this branch contain the cell body of visceral afferent fibers. For sensory functions, the vagus nerve have three branches, which are somatic afferent, special visceral afferent, and general visceral afferent. For motor functions, vagus nerve has special visceral efferent and parasympathetic branch, which is general visceral efferent. The motor fibers is located adjacent, nearby, or within visceral structures of the trachea and bronchi of the lung, the heart, and the digestive system. In general, the vagus nerve will control the constrictions of the bronchioles, the increased heart rate, increased blood flow, peristalsis, and secretions in the gut. And vagus nerve is also responsible for muscle constrictions for the following muscles and its proprioceptive functions. The central processing of primary vagus sensory afferent fibers enter the spinal trigeminal tract and synapse in the medially adjacent spinal trigeminal nuclei. Somatic sensation functions is represented by somatic afferent input fibers, which are responsible for pain, thermal sensations from small area on the ear and part of the external auditory meatus, the dura of the posterior cranial fossa. Any lesions at the root of the vagus nerve will cause in dysphagia, which is unilateral paralysis of pharyngeal and laryngeal musculature, and dysarthria, which is weakness of the laryngeal muscles and the vocalis muscle, causing speech difficulties. Next is the accessory nerve. This is cranial nerve number 11. This nerve has been described to have two parts, which come from the medulla and spinal part, specifically from the cervical spinal cord. But studies have shown that some of the somatic efferents of motor neuron from these fibers, from this nerve, innervate the sternocleidomastoid and trapezius muscles are located in the cervical cord only, and these muscles are not innervated by motor neurons located in the medulla. The accessory nerve originates from the motor neurons in cervical spinal cords, extending from cervical 1 to cervical 6. Accessory nerve has a motor functions. It innervates the ipsilateral sternocleidomastoids and trapezius for head and shoulder shrugging.
In sitting position, inspect the neck area for atrophy. If no atrophy is apparent, ask him to shrug the shoulders and to not let you push the shoulders down. This assesses the upper trapezius. For the sternocleidomastoid, ask the patient to rotate the head in both directions against the resistance.
Lesions to this nerve root will cause trapezius paralysis, mainly on the ipsilateral side, and sternocleidomastoid paralysis on the contralateral side. Next is the hypoglossal nerve or cranial nerve number 12. The hypoglossal nerve nucleus is located in the internal to the hypoglossal trijoint. Hypoglossal nerve has motor functions that carry general somatic efferent to intrinsic and extrinsic muscles of the tongue. The blood supply to the hypoglossal nucleus and the fibers come from the anterior spinal artery. Any occlusions of these branches, as in medial medullary syndrome, may result in paralysis of geniculus muscles with deviations of the tongue toward the side of the lesions. Patients will also experience contralateral hemiparesis due to cortical spinal tract involvement and contralateral loss of position sense, vibratory sense, and two-point discriminations, because of the anterior spinal artery are also serving these structures. That was my last slide. Should you have any question, you can email me or post your question at our Google Classroom stream. Thank you.